Well, I have one woman who had peritoneal meso who the gynecologist discovered when he was doing a hysterectomy. He felt something funny in the peritoneum, and in the best of surgical traditions, he said, "I'm not sure what it is, so I'll take it out."
And that certainly occurs in the peritoneal more than in the pleural, that a patient's undergoing surgery for another reason, and they see diffuse nodularity, or the patient has an umbilical hernia or some such, and they discover, oops.
Well, from our endpoint in Libby, as I've mentioned before, a predominantly pleural-based disease, which interestingly causes diffuse pleural changes in the parietal pleura, creates a severe amount of pain on a regular basis. It's pain, severe pain in the chest in our population is so common. It's certainly not a good indicator for us. And pleural effusions are so common as a result of that also. So it's clearly a marker in the blood is going to be our best bet. So.
But what I see very commonly is that a patient will have a pleural effusion. That's the fluid around the lung, and they may have it for months or even years, and people will drain fluid out of it, and we don't know what this is, don't worry about it, let's observe it, and that happens multiple times until maybe a year later or 6 months later when somebody realizes, well, maybe we should do a video thoracoscopy and figure out what this is. And so unless people are keyed in to recognize that this could be a possibility, they may not do the right diagnostic procedure.
Thank you. Are there questions, Dr. Levine?
Yeah, as CT scanning becomes a more common screening mode for people at high risk, I think we are going to see more asymptomatic mesos presenting with or without effusions, because when effusions are small, people often don't experience shortness of breath or chest pain. And we have actually picked up a couple early mesos on the basis of really looking for lung cancer with annual CT scans, and it would not surprise me that we're going to see more of that in the future. But I also want to make one comment. I was lucky in my life to be involved in the Libby work. I got dragged into it, not by Brad, but by Aubrey Miller and a community resident who had lost several family members to asbestos-related disease. And the one very striking thing that one experiences if you walk around town with Brad or Tanis or Kimberly is that everyone knows them. Everyone's friendly to them. There is a small sector, a shrinking sector of people in Libby who are still bitter about the hell that's been raised by the Card Clinic over asbestos exposure and asbestos-related disease in that small community, over economic issues of loss of tourism and that sort of thing. It's all understandable. But the most remarkable thing is to see how deeply integrated they are in that community. They don't ride above that community, but they're part and parcel of that community, and it makes them enormously more effective. And it's been a great opportunity for me to work with that group.
If I could make one
Yes, sir.
comment on what Steve said initially. What we are doing in our clinic for people with asbestos exposure, mindful that we co-authored the SMRP paper and the osteopon paper, so we have a bias in terms of these two tumor markers. We actually offer people, and most people take advantage of, a high-resolution 64/high resolution CT, where we process the material, the images through the vitreous system. We do a baseline SMRP, a baseline osteopon, and if you use the right code for SMRP in Michigan, Medicare will reimburse up to $62 for it, which doesn't do you a lot of good when it costs $120. You can get an SMRP through some commercial has around $120. And then we, of course, there will be, within the next 12 months, probably a tumor marker for colon cancer. It was just approved in Germany 6 weeks ago. And there's the same company that makes SMRP may introduce a tumor marker for lung cancers. So what we're doing in our clinic is, even for people who don't have, a frank indicator of a cancer, is offering them the chance for baseline tumor markers.
So we have a similar high-risk asbestos clinic. I think that it's really essential that it not simply be that the patient go to their primary care physician and get a random SMRP. I mean, we do this in a very systematic manner to take a really good occupational history, not only regarding asbestos, but also smoking, because obviously patients are also going to be at risk for lung cancer, and again, do similar SMRP, osteopontin, and CT scan. But I would also argue that this needs to be done in the context of clinical investigation, because we may learn over time what the best way of doing this is, and the only way to do that is to really study it. I also would comment on Steve's comment about it picking things up on CT scans. There actually is a prospective study going on right now in Canada. And there, what they're finding is that far more of the patients they are picking up, at least at this point, actually have lung cancer rather than mesothelioma. Of course, that is also a more common thing, and more lung cancers on this earth were caused by asbestos than mesotheliomas because there are more of them.
I think we had a lady in the white blouse, and then Dr. Frank.
Jill, is that you? I just wanted to know, I know a lot of the statistics that you had put up about how the drugs correlate and the chemo and everything correlates with. Would this fall true also for peritoneal, or was that just mainly for pleural?
So there is the same drugs that work in pleural work in peritoneal. Now, peritoneal is a little bit more difficult to study. Principally because it's a very thin layer often along the abdomen, and it's very difficult often to measure. It's very erratic in its shape, and so it's very difficult to assess. And biologically, peritoneal is a little bit different than pleural. The patients often live longer. Not all of the patients actually have asbestos exposure, and so the biology of the disease is a little bit different, and so therefore those patients are often excluded from studies that include pleural disease. But if you're just looking for, does this drug work in pleural or peritoneal, yes, they both work. They probably work a little bit better in the peritoneal, but the studies often don't include those peritoneal patients.
Dr. Frank?
Yeah, this is really a question for Brad, and I'll make a quick comment first. My involvement with Libby came about through a variety of different reasons, but I must admit, and we'll share, as I've shared with Brad, we'll do so publicly, when we heard that there was this situation in Libby and that it was even somehow different than other asbestos-related diseases or other situations with other groups, I know I was a bit skeptical. I think Steve, if I can speak for our discussion, Steve Levin and I had a discussion, and having been sort of classically trained at the Mount Sinai School about asbestos disease, we thought we knew something about the problem. But in having come to Libby and seen the situation, there are some differences in very striking ways in terms of the presentation of the disease, the symptomatology. And I'm wondering, along with the very important clinical work that you're doing, I see this as an opportunity for some additional basic science to study why is the Libby population affected differently, why with very minimal on CT scan pleural disease do you get so much symptomatology and so forth. And I'm wondering, along with the clinical work, what awareness you have of the potential for doing some interesting and probably important laboratory studies, animal studies to go along with the clinical situation to see if we can understand why the Libby situation, with its mixture of tremolite and winchite and richterite and the vermiculite, why this is different compared to what the more classical presentation has been over time.
Yeah, well, I'll start, and Steve can finish up if he wants, but we are going to be, in our epidemiologic studies that we have already started with the CDC grant, we're going to be looking at some comparisons on disease progression, looking at childhood exposures and health outcomes. But along with this, we're going to add on looks at some of the markers, especially autoantibody markers, working with Harvey Pass, looking at the antiglycan structures. And so, trying to figure out, is something else getting triggered here? Is something in the autoimmune world kicking in at this point and causing rapid progression, things of that nature. Certainly the severe serositis that we see with this that must involve the parietal pleura where the sensory fibers are, seems to be another characteristic that you just don't hear from other people in other populations with the frequency and severity we see. So I think, yeah, we're going to be looking at that. And Steve, you may want to expand on that.
When I heard that, oh, the disease is different in Libby, and didn't come to acknowledge until I actually saw the cases and saw these CT scans, you know, I would say afflicts the rest of the scientific community that looks at asbestos-related disease. And in a way, our epidemiological studies are in part designed to establish the fact that the disease patterns are different there, and that we hope will make possible the investment of research monies into the basic science. In a way, we have to persuade the funding agencies that this isn't your grandfather's asbestos. You know, this is a different disease. And in looking at the difference between what goes on in Libby and the usual asbestos-related disease, we might find some answers to mechanisms, et cetera, that we don't have answers to now. And that's kind of why we shaped the research the way we did.
Hi, my name is Amy Fairman, registered nurse with the Simmons firm, and I have a couple questions real quickly, and I'm not sure who wants to answer them, Dr. Harbert or Dr. Kindler. Dr. Harbert, one of your comments, and correct me if I'm wrong, is you do not have to have asbestosis to develop lung cancer. You just have to have asbestos exposure.
That's correct.
Okay. What are your thoughts about? Are you saying you should at least have pleural plaques then, or you're saying you have to have no proof of underlying radiological evidence?
No. Medically, which I understand is often significantly differently than legally.
Yes, absolutely.
But medically, all you have to do is have asbestos exposure for a mesothelioma to de novo occur, or for a lung cancer to de novo occur, or for a colon cancer.
Okay. And Dr. Kindler, what are your thoughts on mesothelial proliferations and the statistics of them developing into true malignant mesotheliomas? And do you treat mesothelial proliferations in relations to your getting a jump on the disease before it becomes malignant? Do you treat proliferations so they don't become malignant, or do you leave them alone because they're not true malignancies? What are your thoughts on those?
There's no data to show that there is definitely a pre-malignant state in the same way that there is a polyp for colon cancer. And there's also no data to show that there's anything that treating early, at least from a chemotherapeutic perspective, would do anything. Now, should one who has a mesothelial proliferation undergo a pleurectomy, decortication? I don't know that there's any data on that either. Would one find early mesothelioma if one did so? Possibly.
Thank you for your question, but for your first question, I would say, in addition to what Dr. Harbert said, epidemiologically, the data support not having to have any underlying disease, and that asbestosis and lung cancer in an asbestos-related patient are different diseases. They don't depend upon one another to develop, and the epidemiology is pretty strong on this now.
Most patients will have one or the other, and often will not have both.
So anyhow, what do you want me to do, cut my throat? She keeps going like this.